Okay, good afternoon or good morning. This is Dr. Moul. Today I'm doing a webinar on some basics about treating insomnia. This is a talk I'm gearing toward sleep fellows in the main who want to gain some general knowledge and wisdom about how someone like myself approaches the problem of insomnia. A little bit about my background to get you know about me. I'm a sleep psychiatrist. I currently work for the Cleveland Clinic. What I'll say today isn't necessarily a reflection of Cleveland Clinic policy one way or the other. My background is that I graduated as a psychiatrist in 1989. I've done 3 fellowships, one in seasonal affective disorders and circadian rhythms, the second in psychiatric epidemiology, and the third in sleep medicine and psychiatric research. So the talk today will reflect this background that I'm talking to you about. And it's based on some years of working with insomnia patients. Now, one thing I'm asked to remind you all is if you have any questions for the Q&A, to please put these into the Q&A panel, and as I'm able, I will be able to answer them if they come up. Okay, so let's move forward. Now, one of my orienting comments is that sleep isn't coma. It's actually a form of consciousness. We remain arousable during sleep, and that's why it's not coma. And actually, sometimes patients can get the idea that it is, in which case you can get into trouble with prescribing in particular, because people are seeking to be knocked out, in which case they have some lethal risks. We've seen people die this way. So that is a caution to the wise there. My general approach today is to get you started with general practice concepts. I'm not going to go into detail about particular medications. I think that's probably a separate talk. And I think many of you can probably figure out the medicines just from reading. But in general, my lecture today is to review some core attitudes that the sleep-aware clinician has, particularly in the context of process C and S, which are cornerstones of sleep practice in general, and play directly into how we would think about treating insomnia patients. And to discuss some core challenges when treating patients, review the description, obviously, of insomnia. This will be probably part of something that you'll be asked to answer on the boards to some extent. In relationship to treating insomnia with psychotherapy, or what's called Cbti, we should lay out some aspects of habit conditioning as a part of the psychopathology of insomnia. And in general, have some general considerations for organizing care for insomnia. So first of all, the 2 core attitudes of the sleep-aware clinician I emphasize to all sleep medicine fellows and rotators in my clinic. And that is, first of all, to think about the 24-hour functioning of sleep in general in relationship to the pre-process model of sleep regulation. My opinion is this should be taught in high school. It's so basic. And in keeping with that idea about the temporal anatomy of sleep-wake regulation, when we ask about sleep, we should perennially ask about it in relationship to specific time-based questions in our interviews. And by this, I mean questions like, what time do you go to bed? How long does it take you to go to sleep? If you wake up, when would that be? How long will you wake up? When do you get out of bed in the morning? And when you're napping? Of course, where we can, we'd like to get prospective sleep logging. These 2 core attitudes are fundamental to the practice of sleep medicine in general, and are actually very integral to the practice of treating insomnia. And without them, you're not really very sleep aware. I hope that you will really incorporate this in your daily clinical work with patients. Now, let's go over process S and process C for those who may have not seen this before. This is something I will actually teach insomnia patients who are able to understand it, because if I do that, then they will have an idea that what I'm going to ask them to do isn't entirely weird. So let's start with process S. Process S is the process where it generally starts under normal conditions at a minimum at the time you're waking up. It builds up slowly throughout the day as you remain continuously awake. And at the time you go to sleep, this particular pressure is thought to be the basis for the deeper stages of non-REM sleep and helps with sleep onset. Now, one of the things with regard to insomnia is that we like them to avoid naps, because if they take a nap, the effective nap is essentially to bleed off that pressure so that it's not later available when a person goes to sleep. So that's one of the key issues with regard to not napping in the setting of insomnia, which will be different, of course, compared to your advice that you give for someone with narcolepsy. But this is the reason for no napping. Process C is the other process. Now, this isn't based on how long you've been awake, but rather what time your internal body clock thinks it is. And in normal conditions, from 3 to 5 in the morning is when it has its greatest pressure, as you see on the graph. This is more associated with REM sleep. Now, if you've ever come off call, you know that this would be the time when you are actually feeling like you're more awake in the morning. That's because the clock is now pushing you awake, whereas before it was pushing you asleep. In the afternoon, we know that there's liable to be a siesta time as a part of this rhythm. We base this on our knowledge gained from the 90-minute day type of studies that we have. And from the same studies, we also know that the time between somewhere in the evening, this would be the time it is most difficult under the 90-minute day protocol for someone to actually get to sleep, and it's been labeled the forbidden zone of sleep. So this is the temporal architecture of sleep-wake regulation, and is really something I like to say one should have on the inside of one's eyelids when talking to patients. So the basic sleep knowledge is to go back to process C and S. The body clocks is there because it is to help with the predictive physiologic preparation for the day's phases. We're ramping up our cortisol, for example, before getting out in the morning. That allows us to have the stress response prepped for the day's challenges. One of the features, though, is that the body clock has temporal inertia. It doesn't want to change. The reason for this is it's a clock, and it doesn't want to change. And that is the basis for circadian rhythms, of course. But this can be a problem sometimes with insomnia patients, too. So process S, of course, is the body stopwatch for wakefulness, for keeping track of what has already happened throughout the day in regard to continuous wakefulness. So it is basically something that starts when sleep stops and resets with getting sleep. So these are very fundamental aspects and are the basis for not only how we will prescribe medicines, but how we also think about what the sleep psychologist or Cbti or our own sleep psychology is to do with this. So that's the basics. Now, we need to think a little bit about insomnia as a symptom. Now, the word insomnia literally means not sleeping. So in naive English usage, it can mean just inability to sleep or to get rest when it's desired. But in medical language, it means the inability to sleep to get rest in the absence of grossly documentable physical cause. So it's a rule out. But it's not sleep apnea. It's not these other things that you see on the slide. So you want to be able to rule these all out before getting to a diagnosis of primary insomnia, which is an older term, but reflects the fact that that's all you have, just insomnia. The definition from the ICSD official classification for the American Academy is it's a complaint of either difficulty initiating or maintaining sleep or waking up earlier than desired. These are the core symptoms for adults. In the case of kids, it can mean resistance to going to bed on an appropriate schedule or difficulty sleeping without a parent or caregiver. Now, of note, used to be true that non-restorative sleep by itself was part of this classification, but it isn't any longer. Now, this occurs despite the adequate opportunity and circumstances for sleep. It should occur 3 nights a week with some daytime disabilities, be at least 3 months. And this is for a chronic insomnia. It's not due to something else, of course. In terms of daytime consequences, these can include fatigue, problems with attention, work dysfunction, minor mood disturbances, feeling sleepy, and these others that you see. So these are things that patients will be complaining about, so that together, between a daytime consequence and a nighttime complaint, you have the diagnosis of an insomnia. Merely having a disturbed sleep is not enough to make the diagnosis. In the classification, there are different types of insomnia. Short-term, of course, there are things like insomnia related to exams or bereavement. Psychophysiologic insomnia is probably the most prevalent one used in that I'm aware of in clinical practice. Paradoxical insomnia is a kind of insomnia where a person is apparently sleeping but says they haven't. Idiopathic insomnia is one that you would get from childhood. And then you have other insomnias which are related to other causes, as you see. Inadequate sleep hygiene is a part of this classification, usually refers to comparatively minor defects in sleep practices that, once corrected, are sufficient to treat the problem. However, this does not comprise the full spectrum of things that would be under the rubric of something like psychophysiologic insomnia. The prevalence of insomnia is actually quite pronounced. When a very good epidemiologist looked at this some years ago, the symptoms of insomnia, as the nighttime problems, are often 30 to 50% by his account. The symptoms and daytime consequences may comprise 10 to 15%. And dissatisfaction with sleep quality by itself is probably on the order of 10 to 15% as well. And the full diagnosis of primary insomnia, that is, it's not due to something else, when you hunt down and try to find that something else, is about 6%. Now, this isn't depression. This is just can't sleep right. The concept of psychophysiologic insomnia is usually put around the idea of conditioning theory, where the sleep is conditioned to take the bed as a signal to be awake. And this can come out as excessive focus, heightened anxiety about sleep, difficulty falling asleep in your own bed, but being able to sleep somewhere else, being mentally aroused or physically aroused, or intention in bed. These are all things that are thought to be related to the fact that the bed serves as a stimulus to be awake. And of course, it's not explained by another disorder. I will mention some things that I learned in doing the Pittsburgh Insomnia Rating Scale, which I think is very significant for understanding how to think about things. Of course, insomnia can be a complaint, as I mentioned, of other things. And when the controversies come out, are they able to tell the truth about when they're sleeping? That is a controversy that goes back probably 2-3 decades, and it's going back and forth. I will say that in doing the psychometrics, though, one thing that struck out was, in comparison to items that reflect complaints about sleep quality or quality of life or related kinds of questions, these are the things that the patients are going to be more focused on. They're not going to necessarily be focused on the time parameters I told you about earlier in the talk. The time parameters I told you to get are useful for differential diagnosis, but they're not necessarily what the patients care about. So there's a word to the wise on that one. Now, in all of this, treating insomnia is probably very like psychiatry, because we cannot measure symptoms physiologically. The differential diagnosis and treatment of insomnia amounts to a process of educated, systematic guessing. So, for example, the psychophysiologic insomnia story is not something we actually measure necessarily. I don't know that that's been theoretically proven, but when we adopt the theory about it, and guess in accordance with it, we can actually help a lot of people based on those principles. So it's worth remembering that we have to think that we using our background understanding of conditioning and theory to help us figure out what can be useful for patients. Now, in the domain of treating insomnia psychologically, we have Spielman's Insomnia Factors, which have been around since the late 1980s. These comprise predisposing, precipitating, or perpetuating factors. And with the perpetuating factor, I like to think of this as it's almost as if the insomnia wants to have a goal of the patient staying in the insomnia state because of the circulating causes that actually people get stuck in. It's actually the perpetuating causes that are the special target of action in regard to therapists using cognitive behavioral theory treatment for insomnia. Predisposing factors can include female sex, being older, being of anxiety genetics is probably useful to remember. Socioeconomic conditions can be a factor if your neighborhoods are very violent or stress-induced, or occupational expectations can sometimes be an issue as well. I think the poster child for this might be lawyers who cannot stop thinking even when in bed. So these are predisposing factors, which won't necessarily make you have insomnia, but make it more likely for you to develop it. Behavioral activators are precipitating factors. We all probably know they can be fear, worry, pain, noise, hunger, and other things that would be able to set the thing in motion. So they're precipitating. Treatments that have been studied are actually numerous that help with psychophysiologic insomnia. These are things that the therapist for cognitive behavioral therapy will use. At the top of the list is stimulus control, which I would say is probably a standard thing you should recommend in any case. Bed restriction is a little bit more in keeping with what the sleep psychologist will use. Cognitive behavioral therapy as a basket of items works. To some extent, relaxation training will work. There's a specialized technique called paradoxical intention. Scheduled worry time can be a technique of asking someone to worry, but well before bedtime as a structured time for worry to avoid doing so in bed. And of course, sedative hypnotics can also be part of the treatment for this. So the treatment approaches that we would want to use with this would be, first and foremost, get rid of any physiologic or psychological alarms that can be occurring. And this can be, of course, obviously, pain will keep people awake, fears, worry, use of stimulants. First and foremost is to get rid of those alarms, because if they're still in play, they will impair your ability to help the patient sleep. Now, it is an ethical priority to see, if you can, whether cognitive behavioral therapy for insomnia may work for you. The advantage is that it works in a good number of people, not everybody, but it does work in many people. The treatment gets to something like root causes, we think, and will potentially allow you to be able to fix the problem more permanently than use of medication. Now, this is not merely sleep hygiene and shouldn't be advertised as such. You want to get the hackles up of a behavioral sleep specialist say that all they do is sleep hygiene. But the overall approach uses conditioning theory quite actively, with keeping the two-process model in mind in relationship to it. In addition, psychologists will be addressing cognitive and motivational psychotherapy techniques when indicated to address cognitive distortions that occur with insomnia as well as other things. So it's really a complex skill set that you're asking help with if you refer to a behavioral sleep specialist. But also we use sedative hypnotically active medications. Now, in doing this, the idea is that you want to be able to assist the two-process model of sleep. An analogy I give to patients is that this is more like surfing and less like power skiing. Uh, in power skiing, it is the motorboat that pulls you along as you're skiing. That's not what we want from our sleep medicines. What we'd rather have them do is give a power boost so that the patient can catch the wave of this two-process model so that they have more natural sleep. So this is an assistive goal, not a sustained goal. When prescribing, it's important to remember to keep the patient's comorbidities in mind, and this can be both in relationship to opportunities and risks. For example, somebody who has an anxiety disorder as well as sleep might be better off with a medication that, while helping with sleep, will also help with daytime anxiety. Similarly, sometimes a patient's frailty or other risks will be so great that you would not even consider giving a patient a sedative hypnotic because of the risks they impose. So that when prescribing, it's important to take an overview about the overall medical context in which you're giving a medication so that you can take advantage of opportunities and avoid undue risks. Now, in doing this, it's even with either of these approaches, you have to have ongoing monitoring about how the medications are doing. It is not enough just to prescribe and forget about it. Medications can work for a while and fade. They can work for a while and continue, or you may need to do other things to enhance the treatment approach. Now let's turn a little bit to the whole aspect of thinking about conditioning. So conditioning has to do with our daily habits, and sleep habits are no different. I like to think about the issue of just ordinary habits, like the habit of typing in your password on a computer. So that's a habit. And if we have good habits, then it enables us to be more adaptive and fast and carrying out good behaviors for us. But sometimes the habits can be bad and will persist and be non-adaptive, in which case we want to dispense with those habits if we can. So to be autonomous in real life, you need to be a master of one's own habits in order to be a master of one's fate. Now, I like to say the sleep brain is a 2-year-old because if you think about how you learn to sleep, it's actually trained you by your parents when you're 2-year-olds. You're not there to hear about the two-process model. You just follow what your parents direct you to do, and you learn that the bed is about sleep and not something else. So the sleep brain learns by learning habits, and it never grows up. It's still part of us, and this is the way I think about what we're doing with habits. We're really going back to that 2-year-old sleep brain and working with the habits that have gotten out of whack a lot of times. In one thing, though, that's important to recommend is that the practice parameters do not recommend using a sleep study in the setting of the only suspected diagnosis of insomnia. The reason for this is not that you won't find that the patient didn't sleep well during the study, but that knowing that they didn't sleep well doesn't really help you with any management decisions. So it's not helpful in differential diagnosis for the mere presentation of an initial insomnia in the absence of sufficient suspicion for other sleep diagnoses. So let's go and talk about key points about habit management. Well, just like the circadian rhythm, it has inertia. The strength and limitation of a habit is it has inertia. It doesn't want to change. So when you try an old habit, it often tries to fight back. In other words, it wants you to continue what you used to do. If you think about it, when you change your password, often you're going back to what you used to put in. Well, that's an example of extinction bursting, as the psychologists call it. And it's like the old habit is fighting back. It wants to stay the way it was. So when you're trying to change your habits, including sleep habits, you have to think in relationship to the fact that many habits can take 3 or 4 weeks to get firmly established. And this should be a therapeutic expectation that you convey to the patient. Because if you don't, then the patient is going to be coming up against the barrier of the extinction bursting, finding that it's difficult and not persisting to get through to the habits that will be helpful to them. So I have a slide here to illustrate some of these points regarding conditioning theory and its integration with the two-process model. So in this sleep diary, you see that I've charted in some depictions of when the patient may be sleeping. When they're laying down, there's a down arrow, up is an up arrow, and also sleep quality to illustrate what it might look like for a patient with insomnia coming in who happened to do sleep logging. Now, the first aspect I look at in such a depiction is actually sleep quality. And the reason I do that is because I want to capture some days when they actually had very good sleep, because it can be a cognitive distortion that the patient may emphasize on the nights of poor sleep and say, I never sleep well, I can't imagine sleeping well, to be able to point back to them and say, well, look at here, you had some nights that really worked pretty well. And that is when I will emphasize that their sleep brain is actually working the right way, that their brain isn't broken, and try to counteract any kind of cognitive distortions they may have about their brain function. This can be a particularly difficult aspect of treatment, and seeing if I can undermine that cognitive distortion is part of my job. Now, the other thing I would look at on this is there a fixed wake-up time? Now, this is important more for the clock than it is for other things, but if the clock sees morning bright light every morning at the same time, then at least the clock knows where is it supposed to be. But if people are getting up before or after, it's like the person is flipping time zones in some sense, and the clock never really is as clear as to where it is as it could be. So I usually want to have a fixed wake-up time. Indeed, when I'm giving usual standard recommendations, I'll usually emphasize fixed wake-up time and stimulus control. If I just do those things, I've done a lot. Stimulus control, by the way, is the instruction that to associate the bed only with sleep or sex. With the sleep part, it's being that you want to be able to say to the sleep brain, hey, the bed's just about sleep. It's not being awake in bed. It's not being anxious. It's not worrying. It's just about sleep. Now you see what's happened in the next phase of this. You have process C, which has encouraged some afternoon sleeping in the afternoon siesta time. And certainly that's trapped a few naps there, with the result that they burned off process S, and now they're going to have more difficulty going to sleep later. This is fairly common. So avoiding naps has a point. The other aspect, which is somewhat less important than fixed wake-up time, is also a fairly variable bedtime. This is another chaos-inducing kind of problem and gives the perception that sleep is out of control. Generally, I would like to have people have generally the same bedtime, but if I had to compromise, I'm more focused on fixed wake-up time. Now, you can see what process S does here. It's actually building up and pushing the patient initially to sleep in any case. And then the other sleep pressure is actually in process C, as you see here. So in the sense to bed restriction, in some sense, is a matter of delaying bedtimes and pushing process S and process C processes together. Now, interestingly, this is not how our ancestors slept going back before 1800. Usually they had a more first and second sleep approach to this, where they'd be sleeping maybe early in the evening, be awake in the middle of the night, and then be, again, sleeping toward morning. So being awake during the night by itself isn't bad. It's just the aspect of the disability that current modern life gives that has us generally tending to want people to sleep in a more consolidated way in order to encourage sleep quality. And of course, I forgot to mention forbidden zone here. Process S will build up through the forbidden zone. So you want to get people past the forbidden zone before they even attempt to sleep, they will do this by a cue. Usually, they'll have some sense that they're at least getting a feeling of initially feeling some sleepiness. And that's the time when you think about perhaps taking your sleeping pill rather than in the forbidden zone, where if you're taking your pill, all it's going to do is counteract forbidden zone activation and probably not be useful for sleep. Now, if we're thinking about habits, we think across down the table where you're really building up habits. But in my depiction, you also have what I'll call the past habit barrier, or the extinction bursting that the patient must get through in order to be able to sleep well. This doesn't happen in everybody, but it happens commonly enough that you want to warn your patients about it. So some key points about prescribing medications for sleep. A very common problem is that patients won't be necessarily taking that medication in relationship to the physiologic propensity to go to sleep. Now, I mentioned this in relation to the process S, process C aspects to this. Patients will often take the pill early in the evening, hoping that they will get to sleep later, but they're not really getting the full benefit of the medicine. Now, even this rule has exceptions. There are people who do this, and it does help them. But in general, you want to be focused on the proper timing of the medications when it's taken, in order that you can actually get this boost that will help patients get started to sleep or help them with staying asleep. When selecting a medication, you want to base it heuristically on what kind of problem you're facing. For example, if the patient just has a problem with sleep onset, you'd select a medication that just helps with sleep onset more than middle of the night sleep. So a review of your medications as to their onset of action and duration of action will help you. I will say here, I have a handout that if any of you want to get from me electronically, you can email me at mould@ccf.org, and I'll send it to you. It has not only things having to do with medications, but some other topics that I hand out and being part of our fellowship here that may be of use to you. Again, I'll put in a plug for if you have any questions, to be sure to put it in the Q&A panel, and we can go over some of your concerns or curiosities as well. A lot is made when you hear drug talks about FDA approval for insomnia, as if this is somehow some sort of papal blessing. I'm not sure it is. It's important to remember that the FDA approval is only for the permission given to the company to market for the indication of insomnia. There are a number of medications that we give which were permitted to be on the market for other purposes, which we commonly use and commonly use well, and patients benefit. A piece of wisdom I've learned over many years is that any medication can have paradoxical awakening or fade in effectiveness. And that means any. So if you have a person, let's say, who comes in after you've given a dose of zolpidem and they say it woke you up, they're not being crazy. It's actually the way that is. This can happen with just about any medication that you can prescribe. So it's important to believe the patient on these points. The second aspect of this is that any medication can fade in its effectiveness. This probably has to do with the fact that neurons get used to looking at something and they adapt. And so it'll fade in effectiveness. And sometimes it won't, which adds to the bedevilment of treating insomnia and is actually a reason for monitoring how people do over time. Because just because the medication might work for the first week, it may fade by the month's end, and then you're still going to be left with a patient who has trouble sleeping. So in regard to this fading problem, sometimes it's important to reflect with the patient that while a medicine may fade on them from time to time, there may be some usefulness in using it occasionally or in a cycling process, because that way they get some nights where they're sleeping. It's important to get past the idea that somehow a medication will necessarily work for eternity. Now, speaking in regard to benzodiazepine-style medications used for sleeping, I know there's a lot of fear on the part of many medical providers about benzodiazepines and their use. What I will say is that benzodiazepines are neither our friend nor our foe. There is a good time when these benzodiazepines can be helpful for patients. There are patients, for example, who have idiopathic insomnia in my practice who are on standard doses of benzodiazepines, have been so on these for years, sleep well, are happy, and are doing well. There are other people that really get into trouble with these medications. These are actually quite rare if the only indication that you have is for insomnia. That's based on studies from Europe. The other problem with benzodiazepine is that they can lead to fear in the prescriber. Now, if the prescriber is afraid of the patient of the medication, imagine what the patient's going to do. The patient can then be afraid of benzodiazepines or other sleeping medicine, and fear is our enemy in this. Fear is one of the things that's going to prevent sleep. So I take the view that benzodiazepines are neither our friend nor our foe. They have advantages and disadvantages. They're not something I am seeking to prescribe, but on the other hand, they're not something I'm hoping to avoid at all costs. Another point to look with this is to consider combination or rotation approaches in your medicines when necessary. Now, if you're going to do this, I would suggest that you have the patient do some life charting, which is a time graph of how they're sleeping in relationship to their medications. This is a little bit of an expansion of a sleep log, but you can have patients do life charting and slowly figure out that they're good for one medication for 3 days, and they rotate to another for 3 days, and then a third for 3 days. And overall, they're getting consistent sleep over the period of a week or more, but then they're going to need to rotate. Now, this sounds pretty crazy, but it actually works some of the time. And it can give people a sense of having control over their sleep as opposed to being in rather dramatic despair. Whenever prescribing medications as part of every visit, it's important to, again, look for opportunities to consider, again, using psychological approaches, Cbti in particular. Patients can be wanting to come in on medications, and you're not going to convince them otherwise. You give them medications for a while, and eventually they may decide, no, they don't want to do that. They would rather do something else. Well, that's an opportunity then to move them over to cognitive behavioral therapy approaches, which are always the ethically preferred approach in any case, if you can make them work. Sometimes you use both, but whenever you can get any horsepower out of Cbti, I strongly advise doing so. Now, a little comment about that. Cognitive behavioral therapy is actually not widely available. It can be available in larger cities where you have qualified persons. The society working to expand this is increasing rapidly, but you can be left in situations where you just don't have these kind of providers available. In that case, it may be important for you to look for online resources. For example, our own institution has one online resources. There are others where people can actually go online and get programmatic help with using the Cbti approaches in general. One thing I talk to patients about it is that the trade secret to it is to do what the program tells you. For example, stimulus control, fixed wake-up time. Those are the things that are really about training habits, and if followed, help. In fact, the online sites will have been studied and do provide help to a good number of people who take it. I will say, though, that these tend to be people who are a little bit higher functioning, can follow instructions somewhat literally, stick to the plan, and be consistent. I will say that it's often a question about you don't feel comfortable with one treatment modality or another treatment modality. And I will say that the question for this is that I'll say forcing a treatment modality on a patient is unlikely to be effective. If the patient wants Cbti and doesn't want medication, do what you can with Cbti. If they want a medication and they don't want any psychotherapy and they're pretty fixed in their ways about this, well then you probably are going to be using a medication. Our ultimate goal is to help people sleep. It's not to be dogmatic about one treatment modality or another. This is part of what makes it something of a task to do this work. Okay, let's review a little bit the basic approach. I like to teach about two processes of sleep and about habits. This is what I get patients to do. If I can do that, then they are potentially autonomous and know what to do with their sleep, which is one of the business model we have, which is that we don't want repeat customers. In general, we want to enhance the two normal processes of sleep as much as we can. A pearl is that if you're in the doghouse and you don't really know where the person's circadian rhythm is, that should be the first thing you look at. Fixed wake-up time. Because if you don't know that, you're kind of you're lost at sea without a compass or any sense of direction. So if you can figure out where the temporal structure of sleep is in general, then you're on first base. Emphasize compliance with behavioral sleep practices. Now, in doing this, I think it's important to professionally validate what the behavioral sleep specialist is doing. You may have the white coat and the medical authority, and the patients may look to you for the ultimate wisdom, but actually the behavioral sleep medicine specialist is going to know things you're not, or have skills that you're not going to have, or have subtleties that you're not going to know about. So whenever possible, I really try to validate your local provider, because that allows the patient then to listen to that provider or to consider them seriously. You want to remove other factors for fostering wakefulness. Of course, treat pain, remove stimulants, lower alarms in general, if you have the ability to do so. This may involve, for example, finding housing, for example, whatever it takes. As you're able, I would undermine obvious cognitive distortions. That is, I'm never going to sleep, it's terrible, the worst I'm going to die, that kind of stuff. Because that is part of what keeps them with insomnia. And that'll be an issue with that. And if you're using the sleep medicines, use them to synergize with the processes, not to overrule them. Okay, I see I do have a question here. One question is what my email is. That is mould@ccf.org. A second question is, how do you convince a patient to undergo Cbti? Patients often say, someone else is going to tell me how to sleep. Well, I think part of this is, first of all, to re-educate the patient about the two-process model, that there is a temporal anatomy to this, and that we're all victims of our own habits. I like to talk about how the behavioral sleep specialist is more like a coach than like a psychoanalyst. I think many patients come in with the idea, that they're going to get that kind of therapy. But the aspect of someone else is going to tell me how to sleep, if that is the question, I guess the thing to address there is this person would be very concerned about their own autonomy. They don't want to be bossed around. And I'd probably approach this by saying, this is about wisdom that is useful for many people. They have special tricks that people can use and to consider in order to manage their sleep, and see what happens with this. If someone's that focused on their autonomy, it's often kind of difficult, but that might be a way I approach this. Another question just popped up here. Is there a time range in which patients should go to bed ideally for proper sleep? Time range in which patients should go to bed ideally for proper sleep. I don't know that there is. It's more important that they probably have some consistency if they have this. Go back to the fixed wake-up time aspect of this, and try to have the sleep at least as regular as can be, and look for small improvements and really make a big deal about it when it happens, to really emphasize the self-efficacy that's going to be important for this kind of patient to gain a sense of control over sleep by being able to listen to it. Another question just popped up. Does sleep deteriorate during the initial sessions of Cbti? Actually, it can. You got the right idea about my cautioning about the extinction bursting. In fact, it can. And the reason it does is because the old habit was basically wanting to go back to the way it was, that is, to have insomnia. So it can fight back by the patient having difficult sleep for a number of days. They need to be advised of and get through before the new habits can then be practiced enough that they will take hold and supersede the old habits. Okay, basic approach 2. This is just to reiterate just what I was talking about. Set expectations to assess benefit over a 1-month time length for any intervention. So you would say, well, I'm not gonna draw any final conclusions about whether what I were doing today is working or not, whether I'm giving you a sleeping pill or whether I'm doing a behavioral intervention. And for different reasons, but it's the same time period. As we mentioned, Cbti treatments, you got to get through that extinction bursting period, and you can only really assess it after about a month, just as you would for any other habit. And the thing with sleeping pills is they may or may not work. If they do, they may or may not fail after prolonged use, and you need to come back to this after about a month to make sure that this is going to be something like a workable problem if you can. So I recommend about 1 month follow-up for things of this nature. In all of this, keep trying and do not abandon the patient. Because abandonment is a thing which will only increase the alarm, and we don't want to avoid that for sleeping. And if you increase the alarm, it will only make sleeping worse. So it's kind of cruel on their sleep to say to patients, well, I don't know what to do, and you can't come back. One of the things that just came up here, do you follow Beer's criteria and determine the meds for geriatric patients? What meds do you use? Well, I'm glad you brought up the issue of geriatric patients. One thing I will say is that age is not a biological variable. Frailty is a problem that occurs more as you age, but frailty can occur when you're 40. So when I'm thinking about what medications to use for sleep, I take into account, of course, wisdom about using Beer's criteria. That's certainly valid and appropriate. On the other hand, I'm asked not to follow Beer's criteria. I'm asked to help people with their sleep as best I can. So when judging what to do, I'm often looking at risks and opportunities in a particular patient one by one to determine whether or not they should be continued on a particular medication. I will say there are patients that I have that are elderly that are on benzodiazepines for their sleep. I monitor them regularly to make sure that they are remaining safe, not falling, not having cognitive problems, and that they're sleeping okay. And I do not punish them for being older simply because of the Beer's criteria. I will say that when it gets to the point where risks outweigh benefits, I do not prescribe. And in fact, this is what I tell my elderly patients. I will say, at some point, it will get to the point where you're more frail and their risks are going to be outweighing the benefits. And at that point, I will stop your medications, even though I don't want to, insofar as it may help your sleep. It's just that the risks are greater than the benefits. If I do this with elderly patients ahead of time, then they are aware of this. And a number of them will take steps to do what they can to minimize use over time. I've seen successes that way. But I make it collaborative. I don't just make pronouncements that they can't have some medications. As new prescribers, I do ask that you probably get in the habit of setting your own, and I do mean your own, boundary limits for sleep medications. Within our own clinic here, we have different providers who are comfortable with different doses of medications. And I don't think that's wrong or unhealthy. I think what that would tend to do is get into ideological disputes about particular dosing. I do think, though, that each provider should have a comfort limit, a boundary limit for how much of a particular set of hypnotic they're willing to go with the patient. If you don't have those boundary limits, then you're going to be prone to patients wanting more and more and more. And you have to set boundaries, because otherwise you wind up in overprescribing situations, for sure. But I don't know that extreme positions for boundary limits are necessarily helpful for many patients. Okay, let's see. I think this is my last slide. If you have insomnia, you shouldn't worry about it, is one of my somewhat flippant things to say to patients, but it illustrates a key aspect to teach patients that worry can be the enemy, which is, I think, one of the key issues that we are concerned with when talking about stimulus control. Another aspect of this in regard to taking medications is, I say, take the pills or don't take the pill, but don't worry about it. Some patients can get all into an all of a ball about, should I take the medicine? Should I not take the medicine? Should I take the medicine? Should I take the medicine? And that back and forth is actually worry, and I don't want them worrying about a sleeping pill. So they can take the pill or don't take the pill. It's actually another point of thing I would tell you is that there are some patients whose whole cognitive process about worrying about sleep and other things is so vast that you could throw any medication you can think of at an insomnia patient, and it's just going to bounce off the armor of fear, worry, and other cognitions. So often what I'm first doing with these patients is trying to address cognitive aspects of this, because I know that if I don't deal with that, often medications are not going to do much. Treating insomnia is often, but not always, partly a matter of providing some psychological treatment. If you want to treat insomnia, you have to be willing and able to do some psychological treatment. Now, there are some patients for whom this is pretty moot, and I take as an example the patient who has limbic encephalitis, or someone whose insomnia was induced by a major brain damage incident. Those folks probably need medications more than they need psychological treatment, and throwing psychological treatment at such patients is likely to be futile. As I mentioned earlier, fear of taking the pill, not taking the pill, or being addicted can be part of this sleep maintenance problem. And in all of this, some patients can be adversely affected by even the physician's fear of the medications. So with that, I think that's my last slide there. I have some other questions. Do you use any meds not in the recommended list by AASM? Probably. I think most insomnia researchers at some point have used something that's not on the recommended list. You should understand that consensus panels are there looking at literature for generalizable advice that happens with studies done. And if there are no studies that are done, then they can't provide generalizable advice. So what occurs on a recommended list can often be a function of what studies were actually done for the literature. Another question here is, there can be a liable issue if there is a mishap while patient is on a sedative, which is not recommended. I suppose so. You may be correct about this. However, I think that's probably more a question of your documentation and reasoning that you put in your note, particularly if you followed generally a more or less conventional stepwise approach in your care and have documented this carefully and have indicated that you've thought about advantages and risks and also talked to this with the patient. I think that that should suffice for liability. In regard to liability, it's not as though you can never guarantee a result, but you can guarantee that you were thoughtful. Another question here, have you ever used Xyron for stubborn insomnia? Well, that's an interesting one. Yes, I have. This was many years ago. I had a very stubborn psychophysiologic insomnia patient, tried everything else I could think of, and I tried Xyron, and it didn't do anything. So that's a head scratcher. But insomnia isn't necessarily treated by Xyron, even though you think it would. This is another example of how sometimes you'd think things would work, but they don't. And we're coming up against the hour here. Most of the insomnia meds, for example, Ambien is recommended for short time. What is the longest time you've used the Z drugs? There are no good studies on long-term effects of these drugs. Okay. The esopiclone study in the United States established that longer-term care out to 6 months on a medication was now part of the FDA indication framework. Back in the 90s, I was conventional in teaching a 3-week rule about medications such as this because that was the convention. And later on, when I got more insomnia training, I realized that the people who were saying such things actually had patients on Z drugs for quite some time, years in the future. So the licensing by FDA is has been in accordance with 3 weeks, which is usually what they required for drug approval. That's not the same thing as using medication long-term. There are no good studies on long-term effects of these meds. I would agree with you. It's very hard to do a long-term study on long-term effects of these medications because that would involve decades of use. There are cross-sectional and similar studies which would tend to show associations with memory dysfunction, onset of Alzheimer's, and other kinds of things. And while that sounds alarming, I'm not sure that there weren't significant confounds in those studies as to who would actually wind up getting the medications with premorbid conditions already and what would go forward from there. I come back to the question of what are we doing for patients? Our goal is to help them with their problem and avoid non-treatment. Being aware of long-term risks is important, but on the other hand, we don't live forever, and patients do need to sleep. Well, I think that should about wrap up this webinar today. If you want to, again, ask for that handout, my email is mould@ccf.org.